Welcome to Window and Level. Here we break down complex radiology topics and adjust them for clarity. I am Bianca Guedes, and we're back for part 2 of Born Too Soon with Dr. Bianca Guedes. Last week we explored the brain, bowel, and bones and discussed how prematurity affects development across multiple systems. Today we shift focus to the lungs, RDS, and air leaks, things that are essential for diagnostic call. Let's dive in. Welcome back to our series about babies born too soon. We started with the brain because that's often a scary thing when the baby's brain is malfunctioning and the complications associated with it. But let's talk about what happens in the first hours of baby's life in the lungs. Imagine a baby born at 26 weeks, which is not uncommon, as we talked in the previous episode. Why are their lungs in trouble?
Very good question, because we know that exactly at 26 weeks, the alveoli are still forming and surfactant production is very low. So the lungs are very fragile, and I think of it like a sponge that hasn't fully opened yet. So air doesn't distribute evenly, and that's why we have the following conditions.
What does it mean practically? What do these lungs lack?
Usually surfactant is not yet there at this gestational age, so that's why we have significant problems with alveoli production. So they're not well opened. We start to have some changes that we call respiratory distress syndrome, RDS. And with time, we're going to have other chronic changes also associated with the surfactant deficiency, such as BPD, also related with the need of prolonged oxygen supply.
So without surfactant, every breath for the baby is like a battle.
Exactly.
The respiratory distress syndrome is the classic manifestation of that, as you mentioned. Imagine we get a chest x-ray on this baby, 0 days old. What is your workflow? What do you look at first? Is there something you pay attention to?
The first thing that I check, and everyone should check, is the tubes and lines, the tracheal tube position, and then we follow to see the lines, the umbilical lines that are very common in these premature babies. We need to rule out something, for example, iatrogenic, but then we can see how well or low expanded are the lungs, which is quite common in RDS. RDS, we have low lungs expansion. Yeah, we have some patterns to discuss as well.
So what are these?
Granular opacities will look like very fine sand opacities. And then we can also have streaky patterns. So we have coarse opacities with some areas of hyperinflation. They will probably develop chronic lung disease.
Let's go through these patterns. Let's start with granular opacities. How does it look?
We're going to have a very low lung expansion, and granular opacities, usually they are distributed throughout the parenchyma. And sometimes we're going to have also interstitial thickening.
And what is happening in the lung? What kind of conditions this is associated with?
This pattern is associated with RDS, which is a respiratory distress syndrome.
Is that when we lack surfactant?
Yes, associated with lack of surfactant. And when you do the administration of surfactant, you can use the endotracheal tube for that. It's quite common to see the alveoli opening. It's very interesting, by the way. We can kind of see asymmetric opening of these lung fields.
I see. So we can see this irregular expansion of the lungs. How does that look on the x-ray?
Very, very good question, Genia, because sometimes we're going to start to see this asymmetric expansion of some lobes and the other areas are not yet expanded. So they will look like a focal opacity, and we can think about neonatal pneumonia. So a very good tip is we need to compare with the previous images and we need to know about the history, comparison with the previous images, and thinking about the differentials. This asymmetric expansion of the lobes are a quite common pitfall for neonatal pneumonia.
The next pattern is streaky. How do they look?
More linear opacities, and they will reflect interstitial fluid. Sometimes we start to see a little bit of pleural effusion as well, and thickening of the fissures. Next pattern will be a chronic pattern. This is usually associated with prolonged oxygen need. It can be associated with mechanical ventilation per se, but also with just CPAP machines. We start to have hyperinflation of the lungs with cystic-like areas throughout the parenchyma and coarse irregular opacities throughout the lung parenchyma, the bronchopulmonary dysplasia.
Does this coarse opacities only manifest with hyperinflation, or is there any other conditions we could see it with?
They can be seen in other conditions, but these coarse opacities in a premature baby under oxygenotherapy for a long time, it's highly suggestive of BPD.
If I think about babies that were born too late opposed to too soon, are we going to also expect these in Meconium aspiration syndrome, or is it going to look very different?
Very good question. When we have Meconium aspiration syndrome, we're going to have this kind of hyperinflation, but the opacities are very random. They're very irregular. And as you said, history is very important. We need to know if the patient was premature or not to try to go to the correct diagnosis while seeing the expected changes for those pathologies.
I see. If we come back to premature babies with hyperinflation and these coarse opacities, what is the danger of hyperinflation and this barotrauma if they are intubated?
We start to have higher chances of having some complications of barotrauma. The most common one will be pneumothorax, and usually it will come with a sharp pleural line with no lung markings beyond. It has an increased lucency. There are other barotrauma variants as well. We know the pulmonary interstitial emphysema, which is PIE. The air is tracking throughout the interstitial markings. We have this kind of interstitial hyperlucencies. Also, it's quite common in premature neonates to have pneumomediastinum. So the air tracks along the mediastinum. And one very cool, important tip for these newborns is uplifting of the thymus, which is because in adults or in older adolescents, we're going to see that air tracking in between the lung parenchyma and the cardiac silhouette. But in small babies, we have the thymus.
This is a good point about pneumomediastinum. How urgent is the pneumothorax? If I see it on the x-ray in a baby in NICU, how urgent it is for them?
The biggest fear is tension pneumothorax.
How do we differentiate tension pneumothorax versus the normal one?
Usually, it can rapidly compromise ventilation and cardiac output, and it can be fatal. When we start to see mediastinal shift to the contralateral side of the pneumothorax, it's a very high red flag.
If we compare tension pneumothorax versus pulmonary interstitial emphysema, what is clinically worse?
Tension pneumothorax is the highest poor outcome when they don't do a fast intervention. They need to drain this because we have compression of the large vessels and it's a medical emergency. So we need to call them and make sure that they know about the critical finding. PIE is chronic-ish. It doesn't mean that the patient is getting worse very fast. Tension pneumothorax is an urgency.
And what is the biggest risk of tension pneumothorax if it goes unnoticed? What could happen?
The problem is we start to have decreased amount of vascular supply to the whole body of this baby. The patient can develop cardiac arrest and it can be fatal if missed.
These are the calls that we gotta make.
Yes, exactly. Like even if it's like 3 a.m., we need to call them and let them know, and we need to recognize that.
What are you looking for on the follow-up imaging? Are there specific things that you try to track in these premature lungs?
Yes. So on follow-up, usually we're going to assess lung volume, symmetry, and evolution. So a big pitfall is a mistaking re-expanding lung for pneumonia, as we discussed. But also, if the baby is clinically improving, it's probably just recruitment. It's not infection, as we discussed.
How do you define if you need to escalate imaging to the CT? Do we do cross-sectional imaging for these babies?
It's rare to need the CT per se, because we can diagnose almost everything regarding the premature lungs by X-ray. But sometimes CT will be useful when the course is not making much sense and we have a repeated focal opacity in the same lobe. We need to think about other differentials, for example, CPAM or other congenital malformations such as sequestration, lobar emphysema for differentials or problem solving when we have severe complications such as complicated pneumonias or to try to differentiate. of congenital malformations, as we discussed.
Let's name just a couple congenital malformations that could happen in the babies that we could spot on CT.
Yeah, so we can have CPAM, which is the congenital pulmonary airways malformations. Usually they are cystic changes that will be within the lung parenchyma. We have several types of CPAMs, but the major common ones are the cystic changes within the lung parenchyma. Sequestration will be associated with the vascular supply. So usually sequestration will have a systemic vessel arising from the aorta directly to that segment of opacity in the lung parenchyma. And we have congenital lobar emphysema, where you're going to have a segment of lung that is chronically hyperinflated. Usually, even before the baby was born, in the prenatal images, we have hyperinflation of that lung by fluid then. And then after the patient is born, we start to see progressive hyperinflation of that lobe. The CT is helpful, especially to differentiate and to diagnose some hybrid lesions that we can have. Vascular malformation and the sequestration, sometimes associated with CPAMs or other types of conditions.
And as we mentioned, it's kind of more rare, right?
Yes, it's more rare. Yeah.
Another thing that is not uncommon in premature babies, especially very early term, is persistent ductus arteriosus, a PDA. How does that show up on X-ray?
PDA usually will not show up right away, but after a few days, we may see cardiomegaly and increased pulmonary vascular markings due to overcirculation.
Is it like, how many days are we talking?
5 days, usually. Yeah.
And how about if you treat the PDA? Does it reverse all these findings or does it stay the same?
Usually after a few days, we start to see the differences by X-ray as well. So this prominence of the pulmonary vascular markings decrease, and we have decreased amount of cardiomegaly. So it's beautiful to see.
Wonderful. So as usual, serial imaging is the key in the babies.
Yes.
We've covered a lot in this arc: brain complications, bowel complications, and bones. Now we talked about some acute and chronic lung conditions. So what are the core bullet point takeaways for the residents that you would like to share with us today?
First, check tubes and lines. And second, look for air leaks always, right? Thinking about pneumothorax, pneumomediastinum, and other air leaks as well. Assess lung volume and symmetry, and then identify dominant opacities patterns, because we don't want to micro report every single area of the lungs, right? We need to think about the whole picture of that lungs and ask yourself, is this explaining why the baby is so sick right now? You know what I mean? So yeah, I think I will do that.
Wonderful. I love that. And as we talked in the previous episode, behind that is vascular vulnerability.
We know that the brain, for example, has fragile vessels, and usually you're going to have higher chances of have bleedings, especially in the germinal matrix areas. In the lungs, immature vasculature, which will lead to edema and chronic disease. In the bowel, we're going to have poor perfusion that increases the NAC risk, right?
I love how we're talking not just about the imaging findings, but trying to understand what's going on behind it so that we give the best information with understanding of what's actually happening, what's the prognosis of that. As a tradition on the Window and Level podcast, I like to ask unrelated questions to the topic to my guests. And today, I really want to look into the future with you, Dr. Guedes. Have you ever thought about how radiology might change with time? Let's talk 10 years from now, 50 years from now, and 100 years from now. What's radiology going to be like?
Well, very good questions and very hard ones, to be honest. So I think in 10 years, radiology will still be very much physician-driven yet, but heavily supported by AI, as we know. I think AI will help us with detection, triage, and even our workflow, I think. But the radiologist will remain essential for interpretation, integration, and with clinical context and communication, I think.
How about 50 years?
So I think in 50 years, imaging will be probably more predictive than descriptive. I mean, I think we won't just say what we see, but probably what is likely to happen next. I feel like, I don't know, maybe imaging will be deeply connected with the genetic aspect, pathophysiology and the personalized medicine. I think AI will help us a lot as radiologists to spend less time describing images per se and be more time guiding decisions, and the role shifts from imaging readers to clinical imaging strategists, I think, and I hope.
Yeah, that would be amazing. I really hope that someday in the future, radiology will impact care of the patients to a point when we can predict diseases, prevent them, of course, or help to prevent them. How about 100 years? I know it's a long-term distance in the future, but very curious what you think.
I have to say that I have no idea, but I imagine that probably in 100 years, imaging may look completely different from what we know right now. And we might not even recognize the current scanners, for example. But I believe one thing stays the same. Still, we will need probably the human judgment. I think no matter how advanced technology becomes, I think someone still needs to understand disease, context, ethics, impact. I think radiology will be always about trying to translate images into meaning. You know what I mean? It's not about just a diagnosis per se, but it's always about the meaning of that clinical imaging and outcomes.
Yes, it's unimaginable. I can't really even think about what's going to happen in 100 years, but I love how you're directing us towards just keeping radiology great and keeping radiologists active and making decisions for the patients. Even though it's 100 years, probably fully the hardware and the scanners will improve a lot, and which will transform our capabilities to an unimaginable point, as you said. And I really like how you point out the value of human decisions in radiology.
Yes, I totally agree with you. And I think technology will change how we do radiology. Yes, for sure. But it won't change why we do it, I think. At its core, radiology will always be about improving patient care, in my opinion. So, yeah.
Absolutely. This is incredible. The series of babies born too soon have given me a lot of thoughts, and I feel like right now my own pattern when I come back to the reading room will improve and be more structurized. So I very much thank you for that.
No, I have to say thank you so much, Gina. It was super nice to be here with you. Keep going. You're doing a very nice work.
It was amazing to have you today on the podcast, and I look forward to see you again in the future series.
It was my pleasure to be here with you.
This is our episode series, Born Too Soon. We equipped you with knowledge on premature babies, so don't hesitate to grab that radiograph from NICU on your next call. Remember, everything connects with vascular prematurity. And check out our show notes for resources from Dr. Guedes. Now a question to you. What do you think radiology is going to look like in 50 or 100 years? Let us know in the comments. If you found this helpful, subscribe to our channel. This is Window and Level. Thanks for listening.